Tēnā katoa katoa. Welcome, tēnā koutou katoa, sorry. Welcome everybody to our wonderful Rollercoaster Theatre. This is the first of two of our public talks for 2024 here at the University of Otago campus. And it's a chance for us to showcase our mahi, our expertise from our researchers and our clinical researchers, and the work that's going on at this university on issues of big importance to the public, as we're seeing here tonight by all your lovely faces. The mana of women is expressed in many whakatauke, or Maori proverbs, with one being ko te whaia te takare o te waka, which means mothers are the hull of the canoe, they keep the family together. Whether you're a mother or not, a woman, you know, we do hold the waka together. I myself know that, you know, I'm a mother and a very young grandmother with sandwich generation, young adult children, and parents who are getting to need care. That sandwich generation, I find myself in it now. When I was growing up, midlife women's issues, you know, mum and my gran would mutter darkly about the change, and I remember my mum got some HRT and it changed her life. She was totally devoted to her Premarin pills, took far too many of them than she should have, but she loved them and was terrified that she'd have to stop one day. They changed her life. But in those days, it wasn't spoken of, women's midlife issues. It was grin and bear it. You're a woman, that's what you've got to do. A lot of GPs and doctors, there wasn't much they could do or knew about or knew where to refer you and for what. But it's a real growing area of medicine with more and more women clinicians, more and more women's health expertise and research is being done. More is being done now in the workplace. There are some workplaces having menopause leave starting, which is an amazing thing I would never have dreamed possible, even 10 years ago. As a television journalist at One News, I remember once going to one of my news editors and saying, look, I've got a great idea for a 3-part series over Easter. This was about 2007, 2008. I'd love to do a series on women's midlife, you know, menopause, HRT. And I remember distinctly, he said to me, yeah, but Laurelie, why would we do 3 stories when only half the viewers are going to watch them? Which I thought, well, it's a bit ironic, isn't it? Because it's 6:40 every night, 7 nights a week. We have the sports news and I mean, I'm a sports fan, I'm okay, and I know there's some blokes who don't watch sport, but surely that's not everybody's watching that. So I thought, I was sort of brushed aside and told no. I think I managed to get one story out. And it was an important one, because in 2002 a study came out internationally which frightened women. It was saying that HRT was dangerous. It was linked to cancers, it was linked to heart disease. I remember doing the story. But of course that's been debunked. That study has now been disproven. And HRT, you know, and there's a lot more choice. It's safe. You'll be hearing a little bit more about that tonight. There's a lot more options for women. And I really wanted to get that news out there, but it was a bit of a struggle at the time. There's a growing body of international research dedicated to investigating women's midlife issues, as I said, and there's research here on this campus at this university too that we are involved in an effort to improve women's lives, provide treatment solutions, improve screening tools and early diagnosis. For the next hour, we'll hear from 4 experts, all research and clinical leaders in their field, sharing with us their expertise, opinions and evidence about women's midlife health. We've got renowned gynaecological endocrinologist and menopause guru, Dr. Anna Fenton, down the end here. We've got highly respected gynaecological oncologist, colposcopist and researcher Briony Simcock, here in pink. Consultant psychiatrist, researcher and senior lecturer in psychiatry here on campus, Kate Eggleston, Dr. Kate Eggleston, and highly experienced urologist and clinical director of urology here at Te Whara Ora Waitaha, Canterbury, Dr. Giovanni Losco. We're extremely lucky to have them all here. Thank you all so much for taking time out of your busy lives to come here and talk to us today. Quick health and safety. In the event of an emergency, this is basement level, so you don't want to be here. So those are the exit doors up there to head outside if you need to. Toilets, head out to the left, and then go left again at reception. You'll see there's a toilet block there for you. So let's waste no more time. I'll quickly introduce everybody and a little bit more about them before they speak. First of all, Anna Fenton. Well, Dr. Fenton is highly celebrated. She's one of New Zealand's top endocrinologists and a very strong voice of advocacy and wisdom on menopause. She's personally helped hundreds and hundreds of women, myself included, Anna, thank you, navigate a path through midlife with her warmth and intelligence and vast knowledge and no-nonsense expertise. She graduated in medicine at the University of Auckland. We won't hold that against you though, Anna, here tonight. Followed by a PhD in bone density at the University of Melbourne. Has worked as a consultant endocrinological gynaecologist for many years here in Canterbury and Oxford Women's Health, of course. She's clinical lead for bone densitometry at Te Whara Ora Waitaha, Canterbury. She's the immediate past president on the Executive Council of the Australasian Menopause Society, and she was the first New Zealand doctor certified by the North American Menopause Society as a specialist menopause practitioner. Anna has, among many things, served as a member on the board of Osteoporosis New Zealand, and her areas of expertise as well as menopause are premature ovarian failure, premenstrual syndrome and PMDD, polycystic ovarian syndrome, osteoporosis and metabolic bone disease. She's also a senior research fellow in our campus's Department of Psychological Medicine. She's been involved in work we've done and research work on polycystic ovarian syndrome, and there's a wonderful study which is going through the funding application process, which she's hopefully going to be involved in, and Kate too, on women in menopause and their cognitive health. So that sounds great. May I welcome Anna. Anna, come up and speak, please.
Thank you very much. Hopefully everyone can hear me all right. Right, so menopause. So where do we start? I think maybe starting with some of the myths that I hear on a very regular basis in my clinical practice. One of the most common ones, I think, which highlights the misinformation that's often around in the community, it really reflects the group of young women that we see, the sort of 4% of women who reach menopause before 40. They often have years of going to various medical practitioners trying to get a diagnosis made, only to be told that they are too young. Now, my youngest patient hitting menopause was 15, so it can happen at any age, and I think, it's devastating for these young women not to get the care that they need early on. Often we hear the story that Asian women just breeze through menopause without a care in the world. This is a cultural reporting thing. So women of Asian ethnicity tend to be a little bit more withdrawn about talking freely about menopause, but if you ask them, exactly the same proportion as amongst Caucasian women will have symptoms. Often women will present to the primary care practitioner with symptoms that are very consistent with menopause. A blood test might be taken, the blood test is normal, they're told it can't be menopause. And we know that's not true because the hormones around the lead up to menopause are highly variable. They'll fluctuate almost every 20 minutes, day and night. So what you're getting with a blood test is a snapshot of that precise moment in time, and it doesn't really reflect what's going on with a woman's quality of life. So the diagnosis of menopause is very much one made on the basis of talking to the patient, listening to what she's telling you, and not so much on the basis of blood tests. We still hear the comment that hormone therapy is dangerous, very much as a result of the research that Laurelie has alluded to, comments that it increases the risk of heart attacks, strokes and cancers, and we'll have a little bit of a chat about that. You still hear this concept that if women are going to take the risk and use hormone therapy, it should be used in the lowest possible dose for the shortest period of time. And that's a policy that was never based on science, but it's become incredibly ingrained in practice around the world. And that's despite every single guideline over the last 8 years saying that's not how doctors should be practicing. And I think because of the enormous uptick recently in the interest in menopause, we're seeing a bit of backlash starting to happen, and there have been a number of articles, particularly in the British Medical Journal in recent times, that have suggested that we're beginning to over-medicalise what is just a normal part of a woman's life, and she should potentially be left to it to manage it the best way she can. I would hope we've moved beyond those days, but I think it'll be interesting to see how it evolves. So, why do we worry about menopausal symptoms? Well, I think it's now very clear that they have a significant impact on the quality of life of some women at menopause, and also a verifiable economic impact on the workplace. So there's a lot of research going on in that workplace kind of arena. We also know that the women who are having frequent and severe flushing and sweating episodes, particularly if they're night sweats where they're waking up drenched in sweats, these events actually leave permanent scars on the brain that you can actually see on an MRI scan. So they show up as little white dots. And the more of these little white dots you have on a scan, the higher the likelihood that that person will go on to develop dementia or have a stroke. So we're beginning to understand that these kind of severe flushes are not benign events, and they need to be taken really seriously because of this potential impact down the track. I think there's also a bit of a concept that menopause is a short-lived phenomenon. I think we all kind of hope that's the case. Our partners certainly hope it's the case. But the reality is that, there's this preamble of perimenopause, which is very much, the ugly sister of menopause itself. And symptoms can occur for a good 5 to 10 years over that period of time leading up to period stopping. And then on average, there may be another 8 to 10 years from the point the periods have ceased of a symptomatic time. We know that about a quarter of women will have a pretty awful time going through menopause. They're the ones we tend to see and try and help as best we can to move through that phase. And we know that maybe up to a third of us, so it's more than we used to think, will actually have symptoms way beyond that initial 10 years after periods have stopped. So it's not a short process, and it is something that for many women does need to be managed carefully. So the symptoms on this slide are the ones that we can absolutely verify are related to menopause because they classically will go away with the use of hormone therapy. So the temperature balance issues are probably the most well-known of the symptoms that women experience at menopause. And this can be the classical hot flushes or the night sweats. But the thermostat can swing in the other direction as well. So we see women who become, much colder than normal and, have the reverse effect of the hot flushes. The sleep disturbance can be related to waking up hot. It can be related to waking up feeling wired and panicky because of the surge in adrenaline that precedes some of these hot events. But it can be waking up for no good reason, usually in the early hours of the morning, which is one of the most critical phases of our sleep cycle, which is why we end up feeling tired, slightly brain dead the next day. And then, of course, there are all of the genital and urinary issues, which we don't tend, I think, as women to kind of cough up at the first consultation with our doctor. The vaginal dryness becomes an increasing issue with time. We have recurrent bladder infections becoming a bit more of an issue, and women often talk about, again, not readily, but if you ask, about changes in sexual function. And if they come with their partner, that may be one of the things that the partner brings up very early on. We also see the sort of widespread small joint, particularly hands and feet, aches, muscle aches, ligament aches, often very poorly linked to menopause. It's often after the event when someone's been started on treatment, the joint aches go away and suddenly there's a realisation that this has been part of the whole menopause package. These joint and muscle aches are just as common as the flushing and sweating, and probably more common amongst the Asian women. And then we have the mood disturbance, and Kate may address this in a bit more detail, but this often precedes period stopping, and it can occur in women who have never before had any issues with their mental health. It may range from mild changes in mood to quite significant anxiety and panic attacks, anger, irritability. So that can have a bit of an impact, obviously, on their relationship. So those are the symptoms that we're pretty happy are linked to the disappearance of estrogen, our main female hormone, at menopause. And then there are these ones, which are the ones, particularly the first one on the list, that drive every woman I see completely batty. Almost all of us gain weight and change shape at menopause and turn from pears into apples. That weight will stick like glue, and even amongst the most virtuous of women who have perfect diets, regular exercise programs, it just does not easily shift. It does ultimately all sort itself out, but it would be the one lingering issue that I think I say to women, I would get a Nobel Peace Prize if I could solve this. So it is a tricky one. So any consultation has to be kind of prefaced with, this is tricky. And then, the memory, the cognitive fog, the forgetting names, even of your best friend, the word memory issues are very specific to menopause. We don't know what drives those, and they variably respond to estrogen therapy. So there's something else going on there too. So if we come to think about hormone therapy for women, I guess really we're focusing on the women that have got the moderate to severe symptoms that are really having an impact on their quality of life. And if we wanted to summarise what the risks and the benefits of hormone therapy are, I could stand and talk for an hour or two about that, but this is a brief summary of where we're at with the current literature. So the benefits of pretty much any kind of hormone therapy include that women feel better. And I think it's the one thing I prescribe, that women use that phrase that Laurelie used, life-changing. Once you've got it right, it can return their quality of life very much to normal. We know from all the very large studies that have been done, and some of them are ongoing, some of them are really large, following 26,000 women now for 26 years. They tell us that the risk of colon cancer is reduced by about 30% if you're taking hormone therapy, that the risk of fracture, which is obviously an increasingly common problem as we all get older, that's halved. The risk of heart disease is halved by hormone therapy. The risk of death from what they call all causes, which is really deaths from other forms of cancer or dementia, is reduced by about 30%. And contrary to, I guess, the popular concern amongst women that all forms of hormone therapy increase the risk of breast cancer, we know that in the group of women who are just taking estrogen at menopause, so this is the group of women who have had a hysterectomy, they have no need for progesterone to control bleeding, so estrogen's used by itself, that actually halves the death rate from breast cancer. So rather than an increase, it's a decrease. So when we come to use hormone therapy in the normal way, where we add some progesterone to the estrogen to control bleeding in a woman who's still got her uterus, that benefit in terms of breast cancer disappears. So it becomes neutral. If the doctor makes a good choice in the kind of progesterone they prescribe, it may ultimately increase if they make the wrong choice. And that's how we've got some of the more natural forms of progesterone funded by Pharmac in the last couple of years, by convincing them that they're safer, that they would save money down the track in having to deal with adverse outcomes from the wrong progesterone. So I think, certainly prescribing has shifted very much towards the sort of more natural kind of therapies. And then the stroke and clotting risks are really only seen if hormone therapy is started after the age of 60 and oral, so tablet estrogen is used. So we can get around a lot of those risks by using patch or gel estrogen and delivering it through the skin. So what about testosterone? This is becoming quite a popular issue. I think there's a lot of social media, blogs, vlogs, advice that testosterone is the essence, the elixir that we should all be on. There are several issues here. Firstly is that the only reason that we should be prescribing testosterone is to help women with sexual function. There is no other clear indication for its use. There is no data out there from good research studies showing any benefit in any other area for the normal woman reaching menopause at 50 to 51. I think all the guidelines are certainly very clear about that. The problem we have in most parts of the world, and most particularly here in New Zealand, is that we have just one form of testosterone. It comes in a cream, in a tube that lasts 3 months. It costs about $150 if you've got a kind pharmacist, so it's not particularly cheap. I don't think there's any plan on behalf of Pharmac to fund that for women. There's been a lot of confusion recently with a male testosterone gel that's come out, and I've had a lot of my colleagues who have started to prescribe that for women, but the dose is way too high, so Testogel is not appropriate for women. And it does have to be very carefully monitored. You want to make sure if we're prescribing testosterone that we've got the levels sitting in the middle of the normal range for a woman and not outside that, in the hope that we're going to avoid side effects. And the other thing is we've got virtually no long-term safety data with it. So we don't know what it does to the risk of heart disease or breast cancer down the track. And this is just a quick slide showing you in the dark bars, which are the women on testosterone compared to the ones in the light bars. This is looking at all aspects of desire and arousal. So if we are using it for sexual function, you can clearly see that it does have some benefit. Now, I just wanted to touch briefly on the crisis that I'm sure most of you are aware of if you've gone anywhere near patches. It hit absolute rock bottom point 2 weeks ago where no pharmacy in New Zealand had any patches at all. Pharmac tell us this is a global issue. It seems to just affect New Zealand. So we are hoping that they will get a rush of blood to their brain in the very near future and fund a gel as an alternative. They tell us they will. We are optimistic. Watch this space. And then just lastly, I think it's really important for the group of women that we see where hormone therapy is not an option. There will be contraindications such as previous breast cancer where it is just not such a good idea. And it's important for them to be aware and for their doctors to be aware that there are lots of other options to manage their symptoms, whether it be, the complementary therapies and particularly hypnosis, which is incredibly effective. Some of the drugs that are used for all sorts of other purposes in medicine but can be repurposed for use at menopause and are very helpful. And then in Christchurch, we're lucky that we have access to a nerve block that also stops flushing and sweating, or at least attenuates them fairly significantly. So lots of good options. And then just a quick, plug for some good educational resources for you. The Australasian Menopause Society website, Menopause Matters, really excellent, valid, accurate, evidence-based information. And Nikki Bazan's book is awesome. If you want the authoritative guide written by a New Zealand journalist to menopause and its management, that is the book for you. Thank you.
Thank you, Anna. I feel bad, I said that, 12 minutes to each speaker, and gosh, we could hear hours and hours more on just menopause alone from Anna, and it's going to be, the same with all the speakers tonight, I'm sure. Thank you so much. That was really interesting. Dr. Briony Simcock now. Briony's a gynaecological oncologist, highly respected and an expert in the treatment of all gynaecological cancers and precancers, and she's also a highly experienced colposcopist. She gained her medical degree from the University of London and completed her basic training in OBS and gynae both in the UK and New Zealand. She moved to Melbourne to work at the famed Peter MacCallum Cancer Centre before returning to Cambridge in the UK to complete her subspecialist training in gynae oncology. She's worked as a consultant gynae oncologist, a clinical researcher and senior lecturer here on campus since 2008. And I know from talking to her she's got a passionate interest for screening in women's cancers, and has a special interest in complex cases and is heavily involved too in research projects here on campus involving women here in Canterbury who are going through gynaecological cancers and precancers. She was a founding member of the Gracie Foundation. Now, Gracie stands for the Gynaecological Cancer Research and Clinical Innovation. It's a charitable trust formed in 2010 by a small group of professionals with a particular interest in gynae cancers. Its aim is to improve outcomes for women living with gynaecological cancer in New Zealand by supporting New Zealand-based research into it. Welcome, Briony.
Kia ora. Nau mai, haere mai ki tātou, ki tēnei hui. Ngā mihi nui, Suze and the team for organising this such an important thing to do. As a doctor in women's health, just really grateful to have the time to talk about this, and I'll be really grateful that my slides then come up. No, let's try that one. Hey, that's good, isn't it? Ko waio, who am I? So you've heard a little bit about who I am. I trained as an obstetrician gynaecologist, and then I worked in gynae-oncology looking after women with gynecological cancers here in Aotearoa. And the privilege of being able to be part of the care of women with gynecological cancers and work in a team, some of whom are here tonight. Ngā mihi nui kia koutou. Yeah, I am a very lucky person. So a gynae-oncologist, as you've heard, looks after women with a range of gynecological cancers. We don't hear much about gynae cancers, do we? And when I go out to dinner, which I have to say I don't actually often have much of a social life, but I go out and people say, what do you do? And I say, I'm a gynecologist. And people go, ugh. And then you say you're a gynae-oncologist, and that's it. You kind of put in the corner of the room, because I might talk about periods, bleeding, and cancers. But yeah, right. Whew. So, but, information's everything, and I'm so grateful that we live in a time where we're talking about menopause, and we can talk about prolapse and mental health issues, and we can talk about gynae cancers. We can talk about cancers of the ovary, tube, uterus, cervix, vulva. I look after patients with vulva cancer who have never, ever told their best friend that they have vulva cancer because they're embarrassed. It's not right. You can even get tumours in your placenta. Did you know? So I'm hoping. So it took me 3 years to train to be a gynae-oncologist, and honestly, I am still learning. There is still so much to do. And I have to talk to you about 3 years' worth of learning in about 10.5 minutes. So I hope you're on for a... No, it's okay. I want you just to understand a little bit about gynae cancers. And if my only success from this, the only thing you remember, is that they're a thing, and it's okay to talk about them with your friends, kitipai. Well done. That's a massive start. HPV is something that I'm super, super passionate about, and I'll talk a little bit about that. And as you've heard, research is hope, research is understanding, research is progress for all of us. And as I'm getting older, I'm getting more and more desperate in my research, because I might need the benefits of this sooner and sooner. I'm like, oh my God, bring it on. So a little bit about that tonight too. I'm a surgeon, so I'm a really visual kind of person. So I thought you might like to see a bit of what I do. And we're hearing about ovaries. Won't surprise you to know that our ovaries are absolutely amazing, because women are amazing, and we all know this. And there's all sorts of different cells in our ovaries, of course, because the germ cells can go on and produce, if they match up with the sperm, it's kind of irrelevant, really, isn't it, that you can produce babies, but benign ovarian tumours. Here's everybody's favourite. If you're a gynecologist, we all love dermoids, and you can see, honestly, you get teeth in your ovary. It's very cool, and hair, and fat, and all sorts of other things. So benign ovarian tumours are a thing. I know, right? Seriously, that's a washing up bowl, and our ovaries are supposed to be smaller than an egg. And actually, this one wasn't even malignant. It's a benign one, but it weighs about 5 kilos, and that's when I moved from gynecologist into bariatric surgeon in one quick, move. Changing your waistline, and that lady's ovary is actually benign. She was absolutely fine, and there were no further problems. But what we're learning a little bit more about ovarian cancer is that a lot of ovarian cancer evolves from the fallopian tubes. Now, ovarian cancer's got a bad rap, justifiably, because advanced ovarian cancer often presents in older women once it's spread, and it's very difficult to treat. And here we are involved in research looking at low-grade serous ovarian cancer, some other work looking at high-grade serous ovarian cancer. And we think about 50% of these cancers, we now understand through research, not done here, start off in the fallopian tubes. And so for the last 10 years, I've been talking to people saying, if you're going to have a hysterectomy, take the tubes out. If you want to have a surgical contraception, have those tubes taken out. I hate fallopian tubes. Everyone's fallopian tubes should be removed. And seriously, last week in clinic, my colleague and I were discussing that, if I have a broken foot, could somebody just nip in and take my tubes at the same time? Because that would be great. Just saying. Anyway, so that's something that we're working on and thinking about a bit more at the moment. We all understand about screening programs here, right? We understand screening because you walk through airports and they're screening for bombs, and you can have breast screening. and we screen newborns for hearing problems, but you cannot screen for ovarian cancer. And that's one of the problems that we're trying to work out. What can we do? How can we prevent cancers affecting over 300 New Zealand women a year? But a success story in screening is HPV and gynae cancers. Now, I can't quite remember. Yes. My lovely colleague and friend, Pete Seitz, came out with this amazing line, which is HPV and the human race is infested with wart virus. And it's such a but it's so true. Human race relies on procreation. If you procreate, 85% more of us are going to get one of the viruses. They're common, they're everywhere. When I teach the students, I've worked out a cure for this, and it solves global warming. No more sex. and the students who are kind of how old are they? 21, 22? They look, older people go, oh yeah, no, it's an option. Anyway, just saying. Anyway, so HPV is the cause, and we can prevent it. We can prevent the HPV high-risk types sitting inside us and going on to cause cervix cancers and vulvar cancers. Vaccination. Vaccination, vaccination, vaccination. It's free. It's for boys and girls. My poor kids rolled up to the GP. In fact, one of them, I can't remember which of the three it was, took herself along to the GP, and GP said, oh, your Briony's daughter, yeah, you'll be wanting the vaccine, won't you? I'm like, yeah, okay. All our children, boys and girls, get them vaccinated before they've got round to having intercourse, and you can prevent cervix and vulvar cancer. It's a no-brainer. Worldwide, New Zealand only sees a small number of cervix cancers, really. The massive burden of diseases across the world, in the Pacific Islands, in Fiji, in Africa. In New Zealand, the numbers that we get, and actually our numbers are right down here at the bottom. You can see us down there. And you might think, oh, well, sweet. Not so. Just last week in our meeting, we heard about a lady who's got advanced cervix cancer. She's had 4 babies, and nobody has ever said to her, have you had a smear? No one. This is a scam. This lady has, or had, a cervix cancer over there. And the other thing you can see in that picture is her baby's head, because she was diagnosed with cervix cancer when she was pregnant. Nobody thought to ask her about her screening history. She wants me to show you this slide. She's 5 years out, she's well, her baby's now 5. But no woman should have to go through that. It's preventable. We now can self-test with an HPV swab. You don't have to have some doctor sticking a thingy up your what's-it and, oh, it's awful, right? Anyway, women, I think, have been involved in the screening program. Hooray! I think every office should just have a jar of these swabs. And I'm seriously thinking about telling the orthopedic surgeons to have them on the front desk. Why wouldn't you? You can just get it done, sorted, done, safe. Much better than a standard squirky. Anyway, just saying. So if you get offered or you've got the chance, join the self-swab program, talk about it, share it, it's saving lives. We can prevent and eliminate cervix cancer. And finally, little whistle-top tour, endometrial cancer, cancer of the uterus. How long have I got? A minute or so. A few years ago, I met a lady. She was 54. She had a BMI of 54. Her husband works for Coca-Cola, and she used to get $150 worth of free Coca-Cola every month. We know that endometrial cancer is associated with obesity. We know that. And I found out on my wee mission that we have the fastest rate of increase of endometrial cancer in the world, in our young women, and no one's talking about it. And I am mad about that. I'm mad that it's so, and I'm mad that no one's talking about it, and I'm mad that it's not in the papers, and I'm out there talking about it now. Highest rate. This many women 3 years ago. That's what it looks like. Why? Is it choice? I don't think so. It's advertising, and beautiful researchers in Otago, they put cameras on our kids' heads, and they found that these fast food companies, $550 million of advertising in fast food in Australia last year, they deliberately target our kids, our Māori, our Pacific, our low socioeconomic class Nearly 2 times more likely to get one of those 70 fast foods exposures to advertising if you come from one of those demographics. New York Times, a month ago, slave labor in India to harvest sugar for Pepsi and Coca-Cola. These guys know it. They know they're using kids. The women, who they like couples to harvest the sugar cane, so they get married couples, women and men, and they don't like women having periods because it takes them off the fields, and they don't want them to have babies because it takes them off the fields. So 1 in 3 women in India get a hysterectomy, gives us sugar. My women get postmenopausal bleeding, heavy bleeding, get a hysterectomy. Rubbish, rubbish. Just quickly, gynae cancers, don't hear much about them, hard to get money for research. Thank you for talking about Gracie. It's an important thing. Research is progress. And I used to, as you said, I used to work in Cambridge in the UK. And this was my bike path. Anyone that knows me knows I bike everywhere. Yeah, in these, I just tuck my trousers into my socks. It works great. I used to bike along this, and this path, those bars, started appearing on my bike path, and they are actually the gene for the BRCA gene, which is one of the genes that leads to breast and ovarian cancer. And it made me realize that research is part of my life. So I just want to finish by saying knowledge is a gift. We should use it well. Research is fundamental to progress for all of us, whatever our age is. And I really would like to mihi, acknowledge the amazing wahine that I have the absolute privilege of meeting and caring for. Ngā mihi nui kia koutou. Kia ora.
It's all wonderful stuff, isn't it? Fabulous. Thanks so much, Briony. Dr. Kate Eggleston, she's a consultant liaison psychiatrist here in Christchurch, a senior lecturer in our Department of Psychological Medicine, as well as a passionate researcher. She sees many women as patients at Christchurch Women's Hospital. She gained her medical degree at Otago University and completed her clinical years up here in Christchurch, followed by a 6-month stint as a visiting researcher at King's College in London, before returning home to continue her training and research in 2019. Kate's involved in research projects examining the longer-term outcome of mood disorders and interventions to increase the likelihood of response and remission. Her research interests include cognitive and functional recovery in mood disorders. She's currently busy developing a study with the campus's respected Christchurch Health and Development Study, looking at women's midlife health with a focus on mental health and cognitive issues, the one that Anna mentioned before. So that's got to be wonderful work. Welcome, Kate.
Kia ora koutou, ko Kate Eggleston aho. Thanks for the lovely introduction and the really interesting talks so far. Bit intimidating coming after these guys, but we'll see how I go. So I'm a psychiatrist. I'm going to be talking about mental health, and as Anna indicated, the main symptom that we're interested in terms of mental health through menopause is mood problems, so depression. So that's really what I'm going to be talking mainly about today. But I'm going to start with this. Does anyone know why I've got this random slide with marine animals on it? I did want to be a marine biologist at high school, and then I defected and did psychiatry. And I've been looking for an excuse to have a slide with some marine life on it, so this is my chance. So out of over 5,000 mammal species, only 6 go through menopause, and it's these 6. Killer whale, false killer whale, narwhal, beluga, short-finned pilot, and us. So we're pretty rare, actually, in terms of mammal species. And the theory is that we evolved under similar social pressures to these 5 species of whales, so complex intergenerational family systems where there are grandparents, kids and grandkids all living together and helping each other out. Most mammal species just die when they stop reproducing, and as someone who's in my 2nd pregnancy about halfway through, I can kind of identify with that. But we just keep going as humans. So that's just my little bit. The other bit that I wanted to bring in is some historical basis for the link between menopause and psychological symptoms. So this goes back to about 1820, I think, and this French guy, I'm struggling with my pronunciation here, but Charles-Pierre Louis de Gadin, that's all right. So he talked about menopause being related to hysteria or nervous affectation of the uterus. And so hysteria was the idea, we've moved on from it now, but that your uterus moved around the body, and that's what caused women to go crazy, essentially. And that's like I say, we've moved on. It's a while since I did O&G at med school, but I think Briony would attest to the uterus staying most of the time in the right place. Then in the 1950s, these three American guys published in JAMA, which is one of our really eminent medical journals, and they said that menopause was rather unpleasant and possibly dangerous. So quite extreme, and they were the first people to develop a rating scale for menopause symptoms, so that's really where the links come from. But what do we know about the links between menopause and mental health now? We've got some big longitudinal studies worldwide that show some quite worrying figures that your risk of depression in menopause or depression symptoms might be 2 to 4 times that at other times in your life. And between 45 to 70-ish% of women might have depression symptoms in perimenopause. Really important to remember, though, that this is based on depression rating scales, and a lot of depression symptoms are similar to menopause symptoms. So you get sleep disturbance, you get changes in your weight, you get loss of libido. So already you're ticking quite a few boxes on a depression scale. And our evidence about actual depression diagnosis across menopause is much more limited, and Anna and I are hoping that we're going to be able to look at that in a study coming up. If you're thinking about who might be more at risk of developing depression or symptoms of depression during menopause, these are the main risk factors, and they kind of make sense. So people having a lot of hot flushes, people having significant sleep disturbance, lots of stress in your life, and a longer time to go through menopause. The other important thing to think about is a little bit, here we go, is background history of depression. So the blue lines here indicate people with a previous history of depression, and the red lines are women without a history of depression. And you can see on the depression rating scale here on the left, people with a history of depression have much higher depression symptoms through menopause. So if you are someone with a background of depression, it can be more of a risk period, but you also may develop kind of lower grade symptoms if you haven't got that background. There's also some evidence to show that people who are depressed through menopause might look a bit different or have slightly different symptoms to people presenting at other times of life. So mood fluctuations might be more on-off rather than in earlier reproductive age depression where you have persistent low mood. And that's in line with those big fluctuations in hormones that Anna was talking about. Extremely poor sleep, obviously more common, particularly if you're having hot flushes and night sweats. Weight gain, Anna's mentioned as well. Cognitive problems, and then aggression and rage, which could happen at any time, but apparently can happen a bit more during menopause. This is just to show how wildly the hormones fluctuate around during perimenopause, and so Anna talked about this being the lead up of maybe 5 or so years before your periods actually finally stop, and that's when you can get those big on-off mood fluctuations associated with that, and you might feel like one of these orcas going through some very rough seas. Our evidence shows that the depression rate goes back to the kind of baseline rate after your hormones stop fluctuating around so wildly, so that can kind of be helpful to know. Lorelei mentioned some of these things. So this is a lady rushing around a lot. I feel a bit like this sometimes, but midlife is a really busy time. Women are often looking after kids, going really well in careers, looking after homes, trying to fit in hobbies, trying to fit in self-care. There's a lot of stuff to fit in, and this is the idea of kind of rushing woman syndrome, rushing around and not really getting a chance to relax or have some time. You can see she doesn't even have time to put her shoes on, so it's pretty serious. And then this here is the sandwich generation, which Lorelei also mentioned. So this is the idea that as women, probably having kids later, they still have dependent children at home, as well as possibly looking after older parents who might be developing dementia or needing other support. So they're sandwiched between these two slices of bread that they're trying to look after, which can be really stressful. This next slide's just to show the interaction between those two things, so the hormonal, biological basis for mood problems, and then the kind of psychosocial stresses that could contribute. And I think this is like a really good study, which is hard to explain, but I wanted to put it up because I love it so much. So if you look here, this column is very stressful life events at baseline, not many of those. Women in this column had lots of stressful life events at baseline. And grey line is high variability in estrogen, so those big fluctuations in hormones, whereas the dotted line, women weren't having many fluctuations. And you can see here it's only women who had both very stressful events at baseline and high variability in estrogen that had more depression symptoms. So it's just showing that interaction between those things that's really important. So if you're thinking, this sounds like me or someone I don't know, what can be done about it? Luckily, there's lots of things that can help. So if you've got kind of milder symptoms, well, any symptoms, but lifestyle factors are really important. And Briony talked about diet. This is really important as well in terms of mental well-being. Exercise, trying to minimise alcohol, minimise smoking. That actually reduces hot flushes as well. There's a strong link between smoking and having more hot flushes, so there's kind of double bang for your buck. So those things are really important. Trying to enhance some support. So can you stop rushing around and get out of that sandwich? Is there anyone that can help you to do that? There might be other family or friends that could be supportive and give you some assistance, or it could be a professional potentially, particularly if you have more significant symptoms. And then it's kind of similar stuff to usual for depression if you are having more serious symptoms. So you might need psychological input, which would be like talking to a counsellor or a psychologist. You might need to think about medications if your symptoms are more severe. And I think if there's any hint that this is a perimenopausal depression, so you have other symptoms of menopause like hot flushes or joint pains or that kind of thing that Anna talked about before, trialling hormone therapy would be a good first line before jumping into an antidepressant. But there is evidence for antidepressants being helpful in terms of managing depression through menopause as well. And in terms of who you would see, GP would be a good first line person to link in with and see what would be helpful. You might want to see someone like Anna, the local expert. And if things were really serious, you might need to be linked in with the local mental health services or see a psychiatrist potentially or a psychologist. That's all I'm going to say. Thanks very much.
Good to know I'm not going mad, isn't it? That's great. Thank you so much, Kate. And now finally, Dr. Giovanni Losco. Now, Giovanni is a general urologist and a urological surgeon. Originally from Christchurch, Giovanni gained his medical degree, as Kate did, at Otago in 2005. And after completing his clinical and postgrad years, he headed off to the UK to subspecialise in urology. He completed fellowship training in paediatric urology at Birmingham Children's Hospital and gained extensive experience in reconstructive urology, female urology, pelvic organ prolapse, urethroplasty, and urological care of spinal injuries while working at various hospitals in London. And prior to that, he worked in Sydney, where he focused on bladder dysfunction with a particular interest in male and female incontinence. Now, he's a clinical senior lecturer here on campus, and among his many leadership positions, Giovanni is currently the clinical director of urology at Te Whatu Ora Canterbury Waitaha, as well as the clinical lead urology at Te Whatu Ora South Canterbury. He's chair of the New Zealand Urology Clinical Director Group. He's a director of Urology Associates here in Christchurch, a trustee of the Canterbury Urology Research Trust, as the national co-lead at the New Zealand Female Pelvic Mesh Service, and he works too with a number of ACC and Health Ministry committees on reducing surgical mesh harm. Giovanni, welcome.
Thank you very much, Laura Lee, for the warm welcome. Great to see such a wonderful turnout And also particularly to see a few blokes in the audience too. I was quite concerned I would be the only one. So, So I'm going to give you a bit of a little whistle-stop tour tonight of a few key urological issues that affect women, really at all stages in life, to be honest, but particularly in the perimenopause and postmenopause time. So incontinence, as well as female pelvic organ prolapse. A little bit about the bladder. The bladder is a little ball of muscle, a hollow muscle, obviously, because it stores urine, but it is effectively a muscle. And it has two jobs. Its first job is to store urine. So when you don't want to go to the toilet, like all of you sitting here tonight, it just quietly stores urine. And then when you're ready to go to the toilet, its job is to empty. So it has to fill and it has to empty. And it has to do that at a socially appropriate time. Two things can therefore go wrong. It cannot be very good at storing, which means you leak, and that's incontinence, or it can store so well that you can't pee. And that's a problem that actually men have very frequently and is much less common in women because men have prostates. So that's one good thing about not being a bloke. But from what I've learned tonight, there's quite a few tricky things about being a woman. So in terms of urinary incontinence, that falls into two groups. So either your bladder, which is that muscle, isn't very good at relaxing and storing urine. It's squeezing away like this all the time, and that's what we call urge incontinence. So you have to go urgently to the toilet, or overactive bladder. The other potential problem is your sphincter muscle, which is the thing that you squeeze when we talk about pelvic floor muscles. We'll talk about that later. Isn't very good, isn't very tight. In fact, it's a little bit loose, and so you leak with things like coughing and sneezing and jumping. That's what we call stress incontinence. So they're the two specific issues, and you can have a bit of both. And if you have a bit of both, you may need both things to be treated. Firstly, though, overactive bladder. So that's the urge incontinence. And the symptoms that we talk about are urgency, rushing to the toilet, frequency, going often to the toilet, urge incontinence, which is not making it in time. So typically we talk about key in the door. When you're going home, you open the front door, or maybe, these days pushing the button to open your automatic garage door as you're driving up the driveway. You just got to go to the loo straight away. For some reason, every time when you just arrive home, you just have to go to the toilet. So that's your bladder playing tricks on you and doing these extra squeezes. And nocturia, which is getting up at night to go to the toilet. So they're the symptoms that people describe. In terms of treatment, like most things, there are some lifestyle sort of changes that can be made. Then there's often medications or tablets, and then potentially surgery. So people that are prone to an overactive bladder, some foods and drinks tend to be particularly irritating. And caffeinated drinks, like tea and coffee, are particularly bad at that. And it's really interesting seeing people that, do have a problem with urgency and frequency, and we get them to do a thing called a bladder diary, where they measure everything they drink into a jug, and they write it down. Then they pee into a jug, different jug, and measure the volumes of what they pee. And you get an idea about how often they're going to the toilet and how often they're drinking. And some people are having 10, 15 cups of coffee a day, and then they're wondering why they're always going to the toilet. So there are some relationships between what we drink and what we eat as well. Doesn't always fix the problem though, cutting back on tea and coffee entirely. There are some medications, tablets, like oxybutynin and solifenacin, and these work on the chemicals in the bladder muscle which are causing it to squeeze. So they sort of deprive the bladder of those chemicals, so it's not squeezing so much. And then there's a thing called Botox, which many of you will have heard of, but probably not in terms of injecting it into bladders. So we can actually inject Botox into the bladder muscle. It does the same thing it does to the facial muscles. It makes it less wrinkly, and that allows the bladder to relax and store urine. There's also a little nifty device which is like a pacemaker for the bladder, which is not done very commonly because it's very expensive, unfortunately, but it's a little device that actually tells the bladder to squeeze less. So it can be another way of managing overactive bladder. So that's overactive bladder. If we move on to stress incontinence, the other cause of leakage in women, stress incontinence is that issue with the sphincter. So that's the muscle that sits below the bladder, particularly prone to not being so good after childbirth after pregnancy. When I say after pregnancy, what I'm meaning is it's not just vaginal delivery that actually causes problems with the sphincter. So just being pregnant causes issues with the sphincter. Trauma and postmenopause, as the tissues become less estrogenized, they're less strong. There are no drugs really for stress incontinence though. However, the mainstay of treatment is pelvic floor muscle exercises. And the way that I describe pelvic floor muscle exercises to people that mostly you can relate to, if you're in a public place, like right here, and you think you're going to fart, it's this sort of muscle that you squeeze around your back passage to just try and keep the fart in. So that's your pelvic floor muscle exercises. And if you're doing it really well, just sitting there on the seat, no one should be able to tell that you're doing a pelvic floor muscle exercise. Yes? Yes, I can see who's trying. Pelvic floor muscle exercises actually resolve stress incontinence in about 80% of women. And for those that don't, we have some options. So bulking agents are little injections into the sphincter just to make it a little bit more closed, a little bit more tight. And that's delivered by a special needle that goes through the urethra. You can be asleep when that happens under anaesthetic, just to try and coapt the urethra together a little bit more. Very common procedure done around the world using mesh creates a sling like a hammock that supports the urethra. I'm not going to really spend a lot of time on mesh tonight because it's had a lot of airtime and it's had a lot of problems. They're not entirely bad, and it is an operation which is still done around the world. Currently not in New Zealand, which I'll get to in a tick, but it sits under the urethra, which is the water pipe. And when you're coughing and jumping and sneezing, it just stops the urine from leaking out. Some things can go wrong, like infection of the mesh, erosion of the mesh, pain from the mesh, and for those reasons, about a year ago, August of last year, the Director General of Health said that we would not be using mesh in New Zealand for the time being. It's called a pause until a number of processes have been put into place to make it safer and to give women confidence that if you are having a mesh operation, it's going to be okay. And in place of mesh, we have what we call natural tissue slings or autologous slings. So this is a surgical photograph of an incision in the lower part of the tummy, taking a piece of the fascia, which is the tough tissue that keeps our guts on the inside, and forming that into a sling that does exactly what the mesh does, only it doesn't involve the use of mesh because we're using our own tissue. And lots of things can be used, including skin or even tissue from the leg, which is the fascia lata. So that's a bit on incontinence. We're going to move on to prolapse. The issue with pelvic organ prolapse is it's primarily an issue with the support of the pelvic floor. And there's lots of organs in the pelvic floor, the bladder at the front, the uterus sort of in the middle and at the top, and then the rectum at the back. There's also some small bowel there. And it's not the fault of any of those particular organs that they happen to be the one that's prolapsing. They were just in the wrong place at the wrong time above a pelvic floor which isn't strong enough to keep them inside. Another really interesting thing about prolapse is I often ask women about, do you have a prolapse or are you aware of a prolapse? And most people come back and say, my nurse or my doctor has told me I have a prolapse. And that doesn't matter. If it's not causing you symptoms, prolapse is almost normal to a degree. A mild degree of prolapse is almost normal following childbirth, and it doesn't need to be treated. If it's symptomatic, then absolutely things can be done. The main symptom is a bulge, so you feel a bulge or a lump actually extruding externally from the vagina. There can be other things such as pain with sexual intercourse, difficulty emptying the bladder, difficulty emptying the bowel. Some occupations weren't really designed to protect the pelvic floor. So for most people, we get through life without putting our pelvic floor under undue stress, but there are some things that the human body just really wasn't designed to do. So even the best operation for prolapse in the world isn't going to prevent prolapse in every possible situation. Broadly speaking, 3 different things can prolapse. One is the bladder. We call that a cystocele. And the second is the rectum. We call that a rectocele. So that's a bulge of the rectum coming through the vagina. And then third is the uterus itself, or if you've had a previous hysterectomy, what we call the vault, or the apex of the vagina, can descend. And we basically have a grading system based on how much the descent is. So on the far, this side here, when the entire thing's falling out, that's obviously a really significant problem, very obvious. We call that total vault procedentia. But it may just be that the vagina is just still completely inside, the uterus is completely inside the body, but just not quite as high at the top of the vagina that it should be. But that is usually not a problem and almost always doesn't require treatment. What's the relationship between incontinence and prolapse? Often people are given the misimpression that prolapse is causing incontinence or that incontinence is causing prolapse. Whilst there is a relationship, it's important to think of them about quite separately. In my earlier slides about the drugs involved for incontinence or surgeries for incontinence, they are really what you need to do to manage incontinence. Whether or not there's prolapse can be managed quite separately. In terms of treatment options, so again, we have some basic things, lifestyle things. We know that being overweight increases your risk of stress incontinence and increases your risk of prolapse. So trying to lose weight and practicing your pelvic floor exercises is really important. Pessaries are a really useful non-surgical way of managing prolapse. They come in quite a lot of different shapes and sizes. The most common are the ring pessary or the donut shape. Which is a firm plastic ring which comes in lots of different sizes, which is placed inside the vagina and can give really good symptomatic relief. Some people leave them in all the time, some people take them out, and it is possible to be sexually active with a pessary in. So you remove it and you can have sexual activity and you can pop it in again. So it doesn't preclude sexual activity. If those things don't work, or maybe they're just not suitable or acceptable, there are various different types of operation that can be done. And the very simplest is an operation through the vagina, simply using dissolving stitches, not involving the use of surgical mesh. We call those cystocele repairs or rectocele repairs. And they are simple operations to recover from, but like a lot of things that are simple, their success rate in the long term isn't that great. So we find 40-50% of women can have a recurrence in the long term. That was why someone came up with the idea of using mesh for prolapse. Now this turned out to be a reasonably bad idea. And you can see by that photograph on the right, from that person's hands there, that this is a very large piece of mesh. And these are the meshes which have really been banned around the world. Not anything to do with the meshes I mentioned earlier that are on a pause, which are meshes for incontinence. These are the meshes for prolapse, which have caused a lot of problems, which I'll touch on in my final slide. There is one type of mesh for prolapse which is safe though, and that's mesh which is actually placed through the tummy, through the abdomen. It's quite a major operation, but it's the most restorative way of resuspending the pelvic organs in the right place. It's called a sacrocolpopexy. The uterus gets a bit of a bad reputation in prolapse, and historically hysterectomy was seen to be the treatment of prolapse, but actually it's not the uterus's fault, like I said earlier. It's not the uterus's fault that it's falling out, and if all we do is remove it, we're not really fixing the underlying problem, which is to provide that support again to the pelvic floor. Finally, one of the things that is a real privilege to be involved in is a relatively new service in New Zealand. It's just over a year old, called the New Zealand Female Pelvic Mesh Service. And this is a service that came out of a restorative justice activity with Victoria University of Wellington, recognising that a lot of women around the world, but particularly here in Aotearoa, have been harmed by surgical mesh. And there wasn't really a process or a place for those women to go. A lot of women were sort of fobbed off mostly because the clinicians that saw them didn't really understand the problem and didn't really know how to treat it. So there is this service now, which is a single service based in 2 sites, Auckland and Christchurch, where we see women with any type of gynaecological mesh, so mesh for incontinence or prolapse, and have a whole lot of options available, including surgery, but some of these women need psychological help or physiotherapy. all sorts of different things. And this is just to show you that there's a lot to this service. It's a complex service. So there's a lot of people involved, but we are really delighted to actually be able to offer this finally in New Zealand.
Oh, great. Thanks, Giovanni. Gosh, so much information. You guys are all superstars. That was absolutely wonderful. Thank you so much. We are a little bit over time. We won't have time for questions. But look, I'm sure our experts here wouldn't mind staying a few more minutes if you want to come down with a burning question. Would that be all right? Not for very long. Of course, they've got to get away for their tea as well. But if you do want to come and ask, please do. Just before we go, I'd like to thank you all for coming. Particularly the blokes in the audience who've come to clearly either academic reasons or to support the women they love. Good for you. That's fantastic. And may I encourage you back next week for the men's public health talk. We've got a few seats left in the auditorium for that. Men's heart health, GP issues, screening, prostate checks, men's mental health, sleep apnea. You name it. We're covering it all here next week. So same time, same place next Wednesday. That's all from me. Ngā mihi nui, ka kite anō. Please stay safe and have a good journey back. And thank you again all for coming, and thank our team as well. Thank you.